Gentlemen, it's a great honor for me to present my experience and the indications, limitation of en bloc resection on the thoracic spine in primary malignant tumors. The indications for en bloc resection are locally aggressive tumors like the giant cell tumor, the aggressive osteoblastoma, and mono and oligometastasized patients with breast, kidney, or thyroid cancer, and of course, the primary malignant tumors like sarcoma and chordoma. However, these are very rare pathologies. The rationale behind that is that we know that we have increased survival rates if we do an external lesion resection of sarcoma, and we have a reduced local recurrence rate in aggressive osteoblastoma, giant cell tumors, or solitary late metastases. The principle of en bloc spondylectomy is an en bloc resection with anything appropriate margins, which means an extra lesion resection, and the tumor should be covered by a layer of healthy tissue, which means you have to achieve free margins. And the way to do that is that you have to create a tumor-free corridor to release the dural sac with its content. And in most cases, you will find a tumor-free corridor like here, which you can resect and then deliberate the dural sac and do an en bloc resection of the whole vertebral body. Just a few examples are here. Even if both pedicles are affected, you can stay outside the tumor and do an external resection and create this corridor to release the dural sac. Here, a bit more challenging case, a giant cell tumor, where I do a lateral corridor here to release the dural sac, and here are the pathological specimen, and also here we were able to achieve clear margins. Even in tough cases like this, with a malignant fibrous histiocytoma and a large epidural involvement, as you can see here, and a large extraosteal component, you will have a tumor-free corridor here. So even in this challenging case, we were able to perform external lesion resection. Here you see a 3-level en bloc resection with a reconstruction.
Als Rekonstruktion bezeichnet man in den
if you have, or in rare cases where both pedicles are affected, like here in this low-grade osteosarcoma, it's probably the best thing you can do is to do a contaminated marginal resection, as we did here, with a minimum spill of tumor cells, with a front and back reconstruction, as you can see on the X-ray. The technique I would like to explain to you is the front and back reconstruction. We presented that back 2008 in the European Spine Journal, and ever since the technique hasn't changed very much. And I would like to take you through a history of a case. It's a 7-year-old girl named Dania with a history of leukemia and radiation therapy and bone marrow transplantation, and she received a total en bloc spondylectomy T4 to T7. Further challenging comorbidities was a steroid-induced osteoporosis, and she was biopsied, and the histology showed a secondary osteosarcoma T4 to T7. And these are the X-rays and MRI. You can see the osteolysis. She had a quite wide scarring of the biopsy. And you see a lesion of T3, and you see the affection T4, and T5, the solid tumor, and T6, and the affection of the neuroframe in T6, T7. So this is the planning, and I just recommend do a very thorough surgical planning preoperatively. And I like to do this drawing and take it into the OR, put it on the wall, just to make sure we're doing the right thing. And this is a total en bloc specimen T4 to T7, and this is the planned resected specimen. What we do is we leave the biopsy scar and then contaminate biopsy cord on the specimen. Put on pedicle screws T2, T3, T8, and 9. We do wide lateral rib osteotomies on the left and proximal rib osteotomies on the right. We create a tumor-free corridor and release the nerve roots and do a subpleural release on the right, because that's going to be the side we will face downwards when we put the patient on the right. We do left-sided nerve root ligation because here the tumor is too large of extent. We do subtotal disc incision T3, 4, and T7 and 8, and transect completely the posterior annulus, which is very important because from the front, it's hard to get that approach. We do flavotomy and bilateral laminotomy T3 to resect the spinous process T3 as well, and then a temporary rod. Then we have a short break and do a right lateral position. We drape the posterior wound as well, do high thoracotomy on the left side, complete the discectomies, and then we open the posterior wound and do a simultaneous a rotation of that specimen, spondectomy of the 4 vertebral bodies. And you can see here still the skin scar and the corridor of the biopsy corridor still on the resected specimen. And by that, we stay outside the tumor and have a strictly extralesional resection. And here you see the vertebral body, T4, 5, 6, and 7, with a large tumor mass here. And a Gore-Tex patch reconstruction of the chest wall is important as well. Here the post-op X-rays, that was an 8-hour surgery with 3.5 milliliter of blood loss. And I have, yes, 6 years follow-up, so far no evidence of disease. So commonly, thoracic en bloc spondylectomies are rarely single-level resection, but in most cases, multi-level resection. So a nerve root sacrifice is frequently necessary. We know from studies from Japan that up to 3 pairs are neurologically safe. If you have to do more than that, you might end up in ischemic paraplegia. Here are just a couple of examples of osteosarcoma or Ewing sarcoma with multi-level resection. What about the fusion length? Normally, if you have a 2 or 3 level resection, 2 above and 2 below is sufficient. If you have more than 3 levels to resect, as you see on the right side, it's probably safe to instrument 3 levels above and 3 levels below. And don't forget the additional anterior fixation to get maximum stability. As pointed out, excise the scar and the biopsy tract if possible, like here in the 12-year-old girl with the osteosarcoma with a huge laminectomy defect, where we left the skin scar and the corridor on the specimen to get free margins. And we have an 8-year post-op complete remission follow-up of this lady. If you want to start with this technique, well, the easy ones are the 1 level with hardly any soft tissue involvement, with a wide tumor-free corridor, no pre-op surgery at the virgin spine, with a small biopsy tract, and thoracolumbar regions probably the easiest one. Lower lumbar and higher thoracic are the most challenging one. And of course, the psychological burden on the surgical skills are somewhat less in the metastasis compared to primary tumors like sarcoma. The tough ones are the multi-level resection, a large soft tissue involvement, rib involvement, like here in the 4 level, or in another case, a 6 level resection, osteosarcoma with wide bilateral rib osteotomies and nerve root sacrifice. And this patient ended up in ischemic paraplegia. However, she's still alive. She had 12-year post-op follow-up on her, and she's still alive with no evidence of disease. Extensive rib involvement, like in this Ewing sarcoma, might be challenging. And here it's very important to cover the chest wall with a Gore-Tex patch. And here's the girl in the post-op X-rays after en bloc resection of 2 level plus 3 ribs. If you have the rare instance of a single level affection with hardly any soft tissue map, you might go for a posterior only en bloc resection. However, you do not have any anterior control and certainly high mortality. So my choice of preference is certainly the combined posterior and anterior technique. Complication you might end up is, of course, bleeding, dural tears if you have one, closed it very meticulously, neural deficits, infection, or even local recurrence, as pointed out in these cases. This was an interesting complication. The more cases you do, the more long-term complications you will experience. And this was 7 years post-resection of an angiosarcoma, and she had a broken rod, as you can see here, with a kyphus and a pseudarthrosis. So we repaired that, and the surgeon who did it thought, well, I do some correction of the kyphus, but she woke up paraplegic. And you can see here why, because the posterior rib that we had put on as a biological graft fractured and impinged into the spinal canal. So we took her immediately back to theater and decompressed the spinal canal, did this forward reconstruction. Fortunately, she recovered completely. Tips and tricks. This is high-level surgery. You need, first of all, a clear strategy. You need a good radiologist to go through all your X-rays, MRIs, and CT scans to know where is tumor, where do I have a tumor-free corridor. You have to have a profound experience in entry approaches, microsurgery, vascular surgery, and you should be creative when you reconstruct your spine. Like here, we do posterior biological reconstruction with iliac crest grafts, or here with fibula grafts, just to enable a long-term stabilities in young patients. You need an experienced anesthesia team and standby. I always include inform my vascular surgeon. In many cases, I don't need them, but it's a good feeling to have them informed that in case you need them, they are prepared. And again, especially if you have primary tumors like sarcomas, free margins are the primary goal and the prerequisite for survival. Thank you very much for your attention, and best greetings from Germany.
Thank you very much. Any questions from the panelists? Okay, I have a question, which is one of the problems that we face is in these osteoclastomas, and when they recur, it's a big problem. So how do you deal with recurrent osteoclastomas?
Well, the best thing is, of course, to prevent them by doing it right in the first time. So we resect osteoclastomas, giant cell tumors, extralesionally if possible. And if you have recurrences, you might talk to the radiologist or to the oncologist with some adjuvant therapy to decrease the soft tissue involvement, and then go for surgery after this adjuvant therapy to make life a bit easier. But I think the most decisive thing is to do it right from the beginning. And we know that we have a 50% recurrence rate if we do it intralesionally. So try to resect them extralesionally with free margins from the beginning.
Do you use radiation if there is a recurrence, re-recurrence after recurrence, after you do this excision and as well as radiotherapy?
Not routinely, no, not routinely. Radiation doesn't play a major role, no.
Right. Would you use gamma knife or proton beam therapy?
In a giant cell tumor, no.
Recurrent ones?
Even the recurrent ones, no. It's a surgical therapy.
Okay. Thank you very much. I think if there are no further questions,
Raghav, can I ask a question, please?
Sure, Arvind.
Yeah. Dr. Lehmquist, great presentation, great work. I have a basic surgical question to you. You from your X-rays and your presentation, I could see that you use a fibula or a rib to cover the large laminar defect at the back before closure, right? Number one, if you're using these bone grafts, how do you keep that into position? Number one, what is your take on using titanium mesh, opened out like a titanium mesh, and putting bone graft over that?
Very good question. Thank you very much. What we do is in the lumbar spine, especially you have to differentiate. In metastasis patient, you probably do not influence the long-term survivalship. So here, I probably do not pay that much attention to posterior biological reconstruction. But in all the kids and younger patients with the primary sarcomas, I do try to reconstruct the posterior column as well. And what we do is in one level on bloc spondylectomies in the lumbar spine that I take a butterfly graft from the iliac crest, and I just squeeze it in between the remaining spinous processes of the neighboring vertebra and fix it with a transverse connector, number one, and then cover it with bone. If you have larger defects, the titanium mesh is a wonderful idea. You just cover your spinal canal, and then you put on bone graft, allogenic or bone graft on that. Or what we do in longer, in 2 or 3 level on bloc spondylectomies, I like to take autologous fibula grafts. And what we do is, that was your question, I think, we secure them with titanium screws to the upper 2 and lower 2 spinous processes.
Thank you.
Lovely. There are a couple of questions here. One is, I think it's not correct, but how do you deal with circumferential chordoma, number one? And number 2 is en bloc resection possible in cervical spine.
Yes. Well, in circumferential chordoma, that's these are challenging ones, and here we do, of course, all of these cases are discussed in the tumor board, and here proton beam radiation and the radiotherapies do play a major role. So I think also from the literature, what is now recommendable is to do a tumor size reduction and then go for radiotherapy. And in the cervical spine, you always have the problem of the vertebral artery. So what you definitely need to do is to check what is your main and dominant vertebral artery. If you have a non-dominant vertebral artery, you might resect it and occlude it preoperatively with the help of the radiologist. But of course, cervical spine, especially the upper cervical spine, is even a very, very tricky anatomic region. Let's put it this way.
All right. I think we're running late and been getting warnings from the organizers. Thank you very much.
Dr. Raghav, sorry, Dr. Venkatesh here.
Yeah.
Regarding the on-bloc cervical spine resection, I think we should watch Dr. Boreanaz's interview today at evening.
Right.
So he is going to talk about it.
Sure, lovely.
The interview, yeah.
Thanks. Let's move on to the next speaker, Peter Vakoczy. Sorry, once again, treatment strategies for thoracic